Good morning. My name is Jason Wright, and I'd like to give you an update on prostate imaging, specifically some newer applications in PET-CT. This will be a two-part talk. The first part, we'll talk about prostate MRI. We'll go through some context, some conventional detection techniques. I'll talk about the nuts and bolts of multiparametric MRI. We'll address fusion biopsy, the importance of the strength of the magnet when doing MRI, our standardized reporting. We'll go through some example cases, and we'll talk about the role of MRI in prostate cancer screening. So it's projected in 2022, prostate cancer will be the second leading cause of cancer death in men. Breast cancer in women plays a similar role. One of the major challenges of prostate cancer assessment is the initial disease characterization. Our standard tools are PSA, digital rectal examination, and transrectal ultrasound guided biopsy. All of these are subject to varying degrees of inaccuracy. Even samples from radical prostatectomy are subject to variable interpretation. And advances in MRI address these challenges and allow us to better characterize the disease upon initial diagnosis. With transrectal ultrasound guided biopsy, only 1% of the total prostate volume is biopsied. This is usually done with a 12-core model, and within that systematic 12-core model, a false negative rate of up to 38% has been reported in the literature. Apical and anterior tumors are the most commonly missed ones. And this is the reason why. On the right, we have a little cartoon of the prostate. This is anterior. This is posterior. Imagine you're looking at the patient from the side. This would be the bladder up here and the urethra going through. This is a little schematic here on the left of the angles used and the levels used to get this 12-core model. So at the base of the prostate, you get 4 cores. In the midgland, you get 4 cores. And at the apex, you get 4 cores. They're angled off to the periphery because there's concern about damaging the urethra on a standard biopsy. And then you can see on this sagittal view how apical and anterior tumors would often be missed. Closer to the bladder, the prostate, this region of the prostate is called the base, and more distally is called the apex. So if you think about breast cancer screening, it would be really inadequate if all we had were serum biomarkers, manual breast exams, and systematic biopsies, which is basically what we use conventionally in prostate cancer to detect the disease. With MRI, we get a full view of the prostate, and we use multiple sequences. We also, another point here is that we use a standardized reporting system called PIRADS, which takes some cues from the breast reporting system called BIRADS. So here's a multiparametric prostate MRI. This is the 3 primary sequences that we use. You can see that the entire volume of the prostate is clearly visualized. There's good anatomic characterization of the peripheral zone, the central zone, and the anterior fibromuscular stroma. The urethra is there centrally, but not usually seen on a prostate or on most of the exams that we do. I'd like to make a correlation between MRI and pathologic slide staining. So this is an electron micrograph. You can see this single cell faintly visualized on the left, and then with some polarization, suddenly all the intracellular structures become much more distinct. This is an optical stain. Here we have an array of brightly colored pathologic histology slides with chemical stains. And as you know, each one of these stains has a certain function. It brings to the fore certain characteristics of the cell so that we can diagnose the disease. In MRI, we have a similar concept happening. We don't use chemical or optical stains, but we can do multiple sequences. And these sequences allow us to gather different information from the same slice of the patient. So here we have a patient through the liver, the left kidney, and the spleen. On this sequence and this sequence, the only difference is that the fat has been saturated out. Fat and water are both bright in this one. Only water is bright in this one. So this actually becomes very sensitive to looking for edema. These other sequences also have specific function. One that's commonly seen or understood is this in-phase and out-of-phase sequence where you can detect lesions, tissues that have a certain amount of fat in them. But these images are largely why I love doing what I do. I think the variability or the ways in which we can image the body with MRI really come out, it is really spectacular and comes out with some beautiful images. So if I might talk about these sequences as stains, just to continue with the same theme, we have three main stains that we use. So high resolution T2, dynamic contrast enhancement, and diffusion weighted imaging. With the first stain, the high resolution T2, we get the spatial resolution that we need to look at the entire prostate, all of its parts, and identify any focal lesions. This is very sensitive, more sensitive and specific for the central part of the prostate for detecting tumor than the peripheral aspect of the tumor, or of the prostate for detecting tumor. The reason is many benign changes in the peripheral zone can have similar findings as cancer on this sequence. Here's an example. On the left is the T2 weighted high spatial resolution image. I can see all these BPH nodules throughout the central gland. We're at the base of the prostate, near the bladder, and these are the base of the seminal vesicles. By contrast, this is a T1 weighted image of the prostate at the same level. So very clearly you can see how one sequence provides more information than another sequence. The second stain or sequence is the dynamic contrast enhancement. This is helpful because prostate adenocarcinoma enhances earlier than normal tissue, so it stands out. What we have here is what's called temporal resolution. So we watch over time what happens to the tissues as they enhance. Here's a little video to illustrate. Every time this starts over and it's dark, that's the beginning of the scan. And then over time, you can see how the tissues differentially enhance. Notice that in the right posterior aspect of the prostate, we have this early enhancement, which is suspicious for tumor. Another way to show the same temporal resolution is with a color map. So you can overlay the gray scale images of the prostate from the regular MRI with these brightly colored maps. The red, meaning that there's some early peak enhancement in this tissue compared to the rest of the prostate. The third stain or sequence is diffusion weighted, and there's two parallel images that come with this sequence. There's what's called an ADC map, and the other one is called DWI. This has become a very powerful way to identify cancer in the prostate. It's very helpful in identifying prostate cancer in the periphery of the prostate, helps also in the central gland. And interestingly, we can actually measure the values of a region of interest, a lesion in the prostate with this ADC map. And the value that you get when you measure the region of interest on ADC have been shown to be inversely proportional to the Gleason score from the pathologic samples from the same targeted lesion. So for example, if the ADC value in a lesion that I see in the prostate is say around 500, 800 being kind of the cutoff for normal, then I would expect a Gleason score of 7 or higher. If the ADC is much higher, like 900 to 1,000, I would expect a Gleason score less than 7. This is an example of an ADC map on the left and the corresponding DWI image on the right. So I'm looking for dark signal on the ADC map where I can measure my value, and then the corresponding bright signal on the DWI, which confirms that it's a true restricted diffusion. You notice there's other areas in this image that's very dark, but it's also dark on the DWI. So you're looking for this mismatch. So now instead of this random, well, not random, but systematic 1% volume sampling of the prostate, we can do fusion biopsy. So on the MRI, in this case, we've identified a lesion anteriorly in the prostate and drawn a region of interest around it. We've also contoured the prostate itself on the MRI. In the office, during transrectal ultrasound, the urologist is able to select a contour of the prostate that is co-registered with the information from the MRI. And then the region of interest from the MRI is overlaid in essentially augmented reality on the ultrasound images live during the examination. This allows the urologist to target the lesion with as many biopsies as he or she deems fit, and then can do also the regular systematic 12-core biopsy for additional sampling. So the strengths of this MRI transrectal ultrasound fusion biopsy is that it's in office, it's accessible to urologists, and you get those additional systematic cores that would be done otherwise. And those additional cores have been shown to be very valuable. The weakness of this is that sometimes the software fusion that I just described can be inaccurate from time to time. And so, the smaller the target lesion, the higher the chance that the region of interest overlaid on the ultrasound images is not as accurate as we'd like it to be. Another way to get accurate targeted biopsies is to do what's called an in-bore MRI transrectal biopsy. So in this case, the patient just lies in the MRI, and there's a whole setup here of MRI safe materials where the lesion of interest can actually be targeted directly from the MRI images. So the strength here is that it's the most accurate targeting of the lesions. So maybe smaller lesions are more likely to be accurately biopsied in this setting. The weaknesses are the extensive setup, the time, and that there's no additional systematic cores obtained from the prostate gland. Another way to do this is by what's called cognitive fusion biopsy. So there's no digital or actual merging of images from MRI to ultrasound, but a urologist that has a very good understanding of cross-sectional imaging may be able to look at the MR images, do the transrectal ultrasound, and target their needle to the right place in the prostate. So one of the strengths is that there's no added overhead to the biopsy. So that whole fusion biopsy suite costs money for the urologist, and insurance reimbursement for fusion biopsy, as far as I understand, is not increased over just a systematic standard biopsy. One of the weaknesses, though, is just obviously human error. This was a landmark study that came out in Lancet. This studied the value of multiparametric MRI with truss biopsy, pairing them together rather than just separately. And in about 500 men, they found a 27% reduction in biopsies overall because the MRIs were negative. And 18% more cases of clinically significant cancer were detected, and 5% fewer clinically insignificant cancers were detected. This really was a study that launched the popularity and the appropriateness of use of fusion of MRI and fusion biopsies. The American College of Radiology has appropriateness criteria documents, and for prostate cancer, they describe pre-biopsy MRI as an emerging standard. That meaning that before any man undergoes a biopsy to screen for prostate cancer, that a pre-biopsy MRI is recommended. Here's a note on the strength of the magnet that we use. So 3 Tesla MRI is favored over the 1.5 Tesla MRI, simply due to the fact that at 3.0 Tesla, there's just more signal and we get better spatial resolution. Our sensitivity will be a little bit higher. Here's an example of this is not the same patient, but a kind of a typical comparison between what a very nice 3 Tesla MRI scan and an adequate 1.5 Tesla MRI scan can do. We use 1.5 Tesla for prostate cancer studies in patients that have medical devices that are only allowable on 1.5 Tesla and not allowable on 3 Tesla. Another thing that can be done in 1.5 Tesla to increase its accuracy and sensitivity is to use an endorectal coil. So that provides more signal that's very uncomfortable for the patients though. Our standardized reporting is called PIRADS. It's important that when you read a report that has PIRADS, that you understand exactly what we're talking about. The phrase that we use, clinically significant cancer, means that there's a likelihood of a Gleason score of 7 or higher within the prostate, somewhere within the prostate. So MRI is not trying to detect low-grade prostate cancer. It's trying to detect prostate cancer that in almost any scenario would be a candidate for surgery or radiation. Now that's a complex topic in and of itself, but just to realize that this is, if you get a PIRADS 1 very low or PIRADS 2 low, it doesn't mean that there's no prostate cancer in the gland. There could be, Gleason score of 6 or lower in there. But typically those patients are candidates for active surveillance anyway. So we're not as concerned about that low grade prostate cancer. So 1 through 5, very low to very high. Let's see. With regard to targeted biopsy, you can kind of separate these scores into 2 groups. So in a PIRADS 1 or 2, there's not going to be any focal lesion to be biopsied. In a PIRADS 3 through 5, there will be a focal lesion that's been identified and categorized accordingly and will be available for biopsy by the targeted biopsy by the urologist. Okay, so let's see. Here's some examples. So these are typical examples of why we use MRI. The first example is rising PSA and multiple negative transrectal ultrasound guided biopsies. Right. This is this was the earliest application for MRI endorsed by the NCCN criteria. The second one would be just surgical planning. So staging of the prostate, making sure that the margins are clear, that there's no lymphadenopathy, et cetera. Third is for biochemical recurrence, which I'll talk a little bit more in detail. And fourth is for active surveillance. Here's an example in a patient with rising PSA and multiple negative TRUS biopsies. So what we found here is this anterior lesion, right? We talked about this. The systematic biopsies often are peripheral and they miss the anterior tumors from time to time. With a cognitive fusion biopsy, this was sampled and shown to be a Gleason 8 tumor. And so this is some anecdotal evidence for in support of getting pre-biopsy MRIs. This was a Gleason 8 tumor by systematic truss biopsy, and MRI was obtained for staging and surgical planning. So you see this tumor here. Okay, on the right, we have some normal fat planes between the rectum and the prostate. On the left by the tumor, we have this exophytic loss of fat planes. So the tumor has gone beyond the confines of the prostate and encroached on the neurovascular bundle on the left here. This MRI allowed the surgical approach to be changed. This is in biochemical recurrence here, status post complete radical prostatectomy. And this is for radiation planning, so salvage radiation, we call it. And in this case, we're able to identify a 2-centimeter recurrence of prostate tissue at the prostatectomy bed. This is the T2 weighted image. This is DWI. This is the ADC, and this is contrast enhancement. No enlarged lymph nodes were identified, and radiation could be targeted to the recurrent disease with a little bit increased dose to the area identified, as to rather just a standard dose that would be given to someone with rising PSA. This is an elevated PSA patient, multiple negative biopsies. This exam shows that there are no lesions identified. So this score would be a PIRADS 2. It's low, low likelihood of clinically significant prostate cancer. So from this MRI, it gives more confidence that active surveillance can be performed rather than repeating a biopsy. Screening in MRI. So standalone screening by MRI is not recommended. PSA screening is a complex matter. The American College of Family Physicians, American College of Physicians, and USPSTF basically have their own guidelines on when to use PSA for, even just PSA for screening. So there's an evolving role of MRI when PSA is elevated. There's a decision to biopsy versus surveillance, and then questions about whether the PCP or urologist should order the MRI. All of this is really an evolving topic. And right now, it just doesn't make sense to use MRI as a simple screening matter. The role of MRI is in rising PSA and prior negative biopsies is well established and now strongly recommended. Okay, a little recap of part one. Got to keep moving here. So we talked about the context. We talked about PSA and truss biopsy as conventional detection techniques with their challenges. Gave you a little bit of taste of what, how we do MRI and why. The value of ultrasound fusion biopsy, 3 Tesla versus 1.5 Tesla, the PIRADS classification, and some example cases. And again, MRI is not recommended for prostate cancer screening alone, but does have a role in patients with an elevated PSA, and that role is evolving. All right, part 2. So this is an exciting field. Prostate PET has great potential to change the landscape of prostate cancer imaging in the future. We're going to go over some challenges and accurate diagnosis of recurrence and metastatic disease, talk about how PET-CT addresses these challenges, a little bit of nuts and bolts about PET-CT, talk about some of the main PET-CT agents, sodium fluoride, Axiom, PSMA. FDG has a limited role. We'll talk about that. And then we'll talk about which PET-CT to use, PSMA versus Axiom. So biochemical recurrence is the term used for a rising PSA after a prostatectomy or definitive radiation therapy. And standard imaging techniques for common sites of disease are technetium-99m whole body bone scans for bone mets, CT or MRI for lymph nodes, and then MRI for basically prostatectomy surgical beds. The problem here is that technetium whole body bone scan is not very sensitive at low PSA levels. And typically these recurrent levels are very low. PSA is much more sensitive than our conventional imaging techniques for detecting the location of the cancer, the recurrent cancer. Lymph nodes really by size criteria alone can be identified, and these have to be, 1 centimeter larger in short axis. Certainly not enough to detect microscopic metastases. PET-CT is more sensitive to the idea of micrometastases, and the reason is because of this tracer principle. So therapeutic doses of drugs reach a micromolar serum level in order to have a physiologic impact. Radiopharmaceuticals, radionuclides, I should say, can be detected by PET cameras at picomolar and nanomolar concentrations. So at 1,000 or 1,000,000 times less concentrated. So these physiologic targets or medicines may have the same physiologic target, but they will actually cause a physiologic impact on the patient. Tracers have no physiologic impact because of their very low concentration in the blood. Radiopharmaceuticals are compounds, so they're composed of two components, a radionuclide and a pharmaceutical. The radionuclide provides the imaging information, and the pharmaceutical is what delivers the radionuclide to the desired physiologic target. Here's a classic example of iodine, radioactive iodine. The imaging agent is an iodine isotope, 123-131, or in some cases we use technetium. The delivery agent, so you don't need a medicine attached to this because the thyroid concentrates iodine, it acts as its own delivery agent. This is a pinhole image of the thyroid, and this is a whole body scan for someone who has thyroid cancer. F18, fluorodeoxyglucose, is what most of us are familiar with PET-CT. It's called FDG for short. The imaging nuclide is fluorine 18, and the delivery agent is the fluorodeoxyglucose, which is incorporated into normal pathways of glucose metabolism. Nearly all malignancies upregulate metabolic pathways, which makes this such a powerful oncologic imaging modality. Unfortunately, that's not the case for prostate cancer until the cancer becomes markedly dedifferentiated. So along came other agents to help us out with prostate cancer. Axumin has been very successful over several years. The imaging nuclide is, again, fluorine 18. The delivery agent or pharmaceutical is fluciclovine, and it's transported across cell membranes by amino acid transporters. And these transporters are upregulated in most prostate cancer cells. The newest agent has many names. It's based on the prostate-specific membrane antigen. So you'll hear this term PSMA often. It can be tagged with F18 or gallium-68. So the imaging nuclide, again, fluoride, let's take fluorine 18. The delivery agent, we can take an example of PSMA called Pylarify, which is what this scan is here. It binds to prostate cancer cells, which usually contain elevated levels of this antigen on their membranes. Sodium fluoride PET was undergoing a national research trial for several years, and many prostate cancer patients underwent these scans in the past. Unfortunately, CMS decided not to pay for it anymore, so it's not done commonly. But this, again, the imaging nuclide is fluorine 18. The delivery agent is just fluoride salt, which is incorporated into the normal pathways of cortical bone formation, specifically osteoblasts. And prostate metastases cause focal upregulation of osteoblast activity. So this is how it was helpful in the detection of prostate cancer metastases. You can identify what agent is being used simply by the biodistribution or signatures of these tracers: Axumin, PSMA, FDG, and sodium fluoride in this case. Prostate radiotracers have a lot of different pathways. We talked about this, Axumin here, and PSMA here. Here's the FDG example. We haven't talked, you'll hear me talk about carbon-11 choline a little bit down the road, but we won't get into that much here. And then this here is prostasant. That was actually one of the earliest prostate-specific nuclear radiology tracers available. So Axiom versus CT versus just a conventional CT for detection of recurrence. A landmark Emory study. All these studies I'm going to describe were between 8 and 15 years ago. This was with about 50 patients. The Axiom showed a 4-fold true positive rate and double the accuracy rate compared to CT. A phase 3 clinical trial called Falcon had 85 patients, and Axiom scans led to a change in treatment plan for 52 men out of 85. So either the radiation field was adjusted or they decided on systemic therapy instead of just salvage radiation. Axiom versus C11 choline, which at the time of the study, this agent was already established as a successful imaging tracer for prostate cancer. This was a European study with 50 patients. Axiom identified disease in 6 patients with negative choline exams. All of the positive choline scans were also Axiom positive, and 33 patients were negative for both agents. So it picked up an additional 6 patients in that group, suggesting that Axiom was more sensitive and specific than the choline test. Axiom versus Prostate. Okay, another Emory study, about 90 patients. Axiom had better, across the board, had better numbers in the detection of prostate cancer in the prostatectomy bed, extraprostatic disease, and the numbers bear out here. But we don't have time to go through those in detail. Probably not much interest either. Here's a local example at our own imaging centers of Axiom versus MRI. So this was an MRI in a patient who had received radiation therapy to the prostate for prostate cancer. On the dynamic contrast enhanced sequence, there was this little 1.5 centimeter focus of equivocal enhancement that was suspicious, but not very specific. An Axiom scan was subsequently obtained. And this little focus down here, this brighter focus above is the bladder. You can see on the cross-sectional fusion image corresponds very well to the finding on the MRI and was confirmatory, 100%, that's the location of the recurrent cancer, causing that the elevation in PSA after treatment. So FDA and CMS approval of Axiom. This becomes important for all PET-CT exams, all nuclear medicine exams, and there's a lot on the horizon, so this will be a common topic. But for Axiom, the FDA approved it for recurrence. So in a patient who's already treated and their PSA is now rising. CMS granted the first approval in 2017 with a pass-through status. It's since undergone, it received its own CPT code, to my understanding. And most private insurances are covering this study for patients that meet criteria for recurrence. It just requires quite a bit of work to gather all of the information on the patient to ensure that insurance will cover them. So Axiom versus PSMA. A 2019 UCLA study did a head-to-head trial of Axiom versus PSMA. And what they did nicely here is they compared groups of patients with different levels of PSA, rising PSA. So in 50 patients with biochemical recurrence, PSA levels of 0.2 to 2.0. For those in the 0.2 range, detection rate was 56% PSMA. That means in 50% of the patients with a PSA of only 0.2, a lesion was identified to account for that rise. By comparison, only 28% were identified by Axiom. In the 0.5 PSA subset, there was similar benefit of PSMA over Axiom, not quite as drastic, but 46% versus 27. And as the PSA subsets go up and approach 2.0, there's less difference. The meta-analysis from 2022, excuse me, of 500 patients showed that in PSA levels of 1.0 to 1.9, PSMA had an 80% detection rate, Axiom 62%. And then in the lower range, 0.5 to 0.9, it was 59 versus 48%. And in less than 0.5, it was 45 versus 37%. So as expected, different studies show a little bit different results. But the point here is that PSMA is proving to be more sensitive than Axiom across the board for identifying lesions of interest in patients with rising PSA after treatment of prostate cancer. Here's a visual comparison of Axiom versus PSMA. These red arrows here show the tiny foci of uptake, tracer uptake in very small lymph nodes, which are not detectable on Axiom. So given these findings here, a radiation oncologist could target those lesions to further treat a patient with a rising PSA and evidence of recurrence. The Osprey and Condor trials were the landmark trials for PSMA. One was geared towards initial staging of cancer, so prior to treatment, and the other with regard to recurrence after treatment. The Osprey trial showed initial staging in high-risk patients that compared to they used radical prostatectomy and pelvic node packets to determine the sensitivity and specificity of PSMA. And there was high specificity, positive predictive value, and negative predictive value, but low sensitivity in this study. The reason is possibly because there was no size criteria limit to the histopathology truth standard. So nodes that were very, very small were collected and shown to be positive that were not identified by PSMA. The Condor trial was for recurrence and negative conventional imaging. So a CT or MRI did not show enlarged nodes, could not identify a lesion in the prostatectomy bed or treated prostate gland. And in those patients, 60% of their treatment plans changed because the site of disease was identified. Okay, so FDA and CMS approval of PSMA, specifically Pylarify, that's the one that's most recently occurred. As I said before, there are several versions of the PSMA tracer. FDA approved PSMA for recurrence and staging, initial staging of high-risk disease. By comparison, Axiom was FDA approved only for recurrence. Conventional imaging is not required according to the FDA prior to the use of Pylarify. And this provides nationwide access to PSMA PET. It's the first agent available. There was early approval of a gallium-based PSMA, but it was limited access to academic sites in California. With regard to local availability, the CMS assigned a pass-through billing code to Pylarify effective as of January 1st. So we're about 5 to 6 weeks into that. It is currently available at our local radio pharmacy, and Radiology Limited right now is testing insurance coverage and reimbursement. So hopefully that will pan out in just a few months, and we'll be able to scan patients as needed. Dose cost from the manufacturer is very expensive at $4,500. So there are some hurdles there and some significant risk if the study is not covered, financial risk. Last point here. So in the near future, there's this concept called theranostics, a combination of therapy and diagnostics. And in prostate cancer, this could turn out to be very big in the treatment of recurrent prostate cancer, or even in initial prostate cancer, but that will be much farther down the road. F18 PSMA can be used as a planning for treatment. Instead of F18 tagged PSMA, lutetium-177, which is a strong beta emitter, delivers treatment level radiation to all of the sites of prostate cancer metastases in the patient. Radiology Limited and TMC of note are working together to begin participation in some phase 3 trials for this lutetium-177 PSMA. Also in combination with a primary investigator urologist in the community that will be taking care of those patients. So lastly, to recap, we talked about the challenges in accurate diagnosis of recurrence and metastatic disease, how PET-CT addresses these challenges, talked about the tracer principle, radionuclides and their pharmaceutical companion, how one is an imaging agent, the other one delivers the imaging agent to its physiologic target. We went through some of the standard PET-CT scans for prostate cancer. And this, I should talk about a little bit more clearly. We do not use FDG in run-of-the-mill prostate cancer imaging. This is only useful in patients who have castrate-resistant metastatic prostate cancer that's been shown to have dedifferentiated and consequently will be highly metabolically active and amenable to FDG imaging. The vast majority of prostate cancer imaging for PET will be done by Axumin or PSMA. We talked about the studies that show that PSMA seems to be more sensitive and specific than Axumin. However, some financial pressures will determine, at least in the short run, which of these two studies is most practical to use for your patients. Thank you very much.